Great. So this is 2019 booklet, but we are solving the ops and gynae part of it. The ops and gynae part of it. So let's see how it goes for today. All right. It's not a lot. There's very few questions. They're not a lot. And most of them we have already done them. So nothing to be scared of. Okay, so we are having a pregnant woman who is 28 years old. On anamnesis, there's what accelerated labor complicated by second-degree cervical rupture. Second-degree cervical rupture or cervical rupture. The following two pregnancies resulted in a spontaneous abortion at 10, 12, and 14 weeks. On mirror examination, the uterine cervix is scarred from previous ruptures at 9 and 3 hours. The cervical canal is gaping. On vaginal examination, the cervix is 2 centimeters long. External orifice is open. Guys, notice the fact that the external orifice is what? Is open. The internal orifice is half open. So again, it means it's also open. The uterus is enlarged up to 12 weeks of pregnancy. So you are pregnant and then you are having what? Your cervical os or the birth canal opened. It is soft, mobile, painless. Appendages are without changes. What diagnosis can be made? What diagnosis can be made? And again, you see when you are pregnant or when you are 12 weeks pregnant, your cervix shouldn't be open because you're not in labor. Your cervix should be open. And if you could realize from the analysis, because the cervix is open or has been opening in previous pregnancies, it resulted in spontaneous abortions. It resulted in spontaneous abortion, one at 12 weeks, the other one at 14 weeks. And now we're having what, 12 weeks. So it's possible that if care is not taken, this pregnancy can also lead to what? Can also lead to what? Abortion. So what diagnosis are we having, or what condition is this pregnant woman having? So easily, we are having what we call what? Cervical insufficiency. Cervical insufficiency. And this is having a habitual non-carrying of pregnancy. So it's not able to carry what? Pregnancy. Why? Because the cervix is insufficient, or the opening is not able to be closed. The cervix is not able to be closed for it to hold the pregnancy intact. And that's why we are having the abortions that have been occurring in this woman. So over here, we are looking at what? At ischemicocervical insufficiency. And it is what? A habitual non-carrying of pregnancy. So your answer here should be C. C. All right. On the day 4, after cesarean session, a woman developed fever with bloody temperature up to 39 degrees. Guys, look at it. Cesarean session, which is, of course, a medical emergency, isn't it? An operation. And after the operation, we're having what? Increase in temperature and abdominal pains. Pulse is 104. She vomited twice. Patient is sluggish. Tongue is dry and has gray coating. Abdomen is distended. Guy, look, there's a sign of peritoneal irritation. It is positive. Peristalsis cannot be auscultated. No passages of gas occurs. Uterine fundus, blah, 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 blah. Now, what are they trying to tell us? Now, as a result of the surgery, and I think I've mentioned it several times, the one thing about surgery when you do is that there can always be what? Be sepsis or infection, or there can be what? Hemorrhage, isn't it? So over here, we're definitely having what? A severe sort of what? Infection. A severe sort of what? Infection. And for them to tell us that peritoneal irritation is positive, tells us that indeed there is what? An infection present. Temperature 39, it tells us that there's what? An infection present, isn't it? And this type of infection, we call it what? Peritonitis. And this is diffuse because it occurs in all segments. Signs of peritoneal irritation are positive in all segments. So this is a diffuse sort of what? Peritonitis. a diffuse peritonitis, which is simply what? An infection. You can put it sepsis, probably. So here, we're looking at what? At a diffuse peritonitis. Diffuse peritonitis. A 58-year-old woman came to the gynecological clinic. She complains of bloody discharge from her genital tract. Guys, look at the age. 58-year-old woman complaining of bloody discharge from her genital tract. We have talked about post-menopausal hemorrhages. We've talked about antepartum hemorrhages and postpartum hemorrhages, isn't it? We've talked about them. So no need for me to go over them over and over again. But for the benefit of revision, we said in antepartum hemorrhage, basically it is caused by what? Placenta presentations, like the placenta previa, placenta abruptio, vasa previa, and so on and so forth, isn't it? Now, PPH or postpartum hemorrhage, that is bleeding right after delivering. We mentioned about 4 T's, and I remember Dr. Jessica helped us with those 4 T's, isn't it? So we're talking about the uterine atony. We are talking about the, how do you call it? We have uterine atony. We're talking about remain of placenta tissues. We're talking about thrombocytopenia or thrombosis. We're talking about what? Laceration or trauma. These are for what? PPH or postpartum. Now, in postmenopausal, that means bleeding after menopause. And 58-year-old man, the woman would have had her menopause already. And we mentioned about the kind of what differentials we can get. It can be endometriosis, it can be cancer, it can be cervical cancer, but there's a distinguished or there is a description that can help you to know this is cervical, this is this is that, this is that. And we discuss it in our therapy, in our Obs and Gynae presentation months ago. So please, this is just to refresh our memory, that's all. But do it to go through the videos. Now, menopause is 8 years ago. Again, it has confirmed that this person is having what? Post-menopausal what? Hemorrhage. Now, gynecological examination. The uterus is slightly enlarged, dense to touch, with limited mobility. The uterine appendages cannot be detected. Parametrium is free. Fractional curettage. Again, fractional curettage or DNC is not only used to scoop things from the womb, isn't it? It can also be used to make a diagnosis. We discussed it the last time. Now, fractional curettage of the uterine cervix yields a significant amount of medullary substance in the scrape. What is the most likely diagnosis? So definitely we are thinking about cancer inside the uterus, because we're having what? Some significant amount of medullary what? Substances right from the what? From scraping the uterine cavity, isn't it? And like we said, curettage is also used what? To make diagnosis. So that's over here. We are having what? A uterine cancer or uterine corpus cancer. Uterine corpus cancer. So your answer is supposed to be what? Should be B. Or your answer is B. Your answer is B. Why? Because of what? Postmenopausal hemorrhage. And as a result, we're having what? When we scraped the uterine cavity, we're having some significant amount of what? Substances from it. And that could be that we're having what? A uterine what? Cancer. Now, in a cervical cancer, they'll be mentioning things like the cauliflower and those kind of things to distinguish between them for you. So over here, your answer is uterine cancer. So your answer is B. Is B. We've done these things, so please. A 48-year-old woman complains of a disturbed menstrual cycle. 48 years, disturbed menstrual cycle. Her period lasted for 7 to 9 days and are excessively profuse throughout the last half year. She noticed occasional hot flashes in her head, insomnia. Guys, menopause is setting in. Her skin is of normal color, blood pressure is 150/90, pulse, blah, blah, blah. The abdomen is soft and painless. By manual examination shows no uterine enlargement. Appendage cannot be detected. The vaginal funnels are free. What is your likely diagnosis? What is your likely diagnosis? Like I said, this person is having what? Menopausal syndrome. Menopausal syndrome. Menopause is setting in already. Menopausal syndrome. Menopausal syndrome. So over here, we are having what? Climacteric syndrome, which is the same as saying we have menopausal syndrome. Climacteric syndrome, same as menopausal syndrome. So your answer here should be what? Should be B. Should be B. We've done these things, so please do well to watch the videos. A 30-year-old woman, multigravida, has been in labor for 18 months. 18 hours. Imagine being in labor for 18 months. For 18 hours. 18 hours. 2 hours ago, the pushing stage began. Okay. Heart rate is clear, rhythmic. Vaginal examination reveals complete cervical dilatation. Fetal head is in the pelvic outlet. That means already the head is what? It's coming down. Sagittal suture is in line with obstetric conjugate. The occipital fontanelle is near the pubis. The patient has been diagnosed with primary uterine inertia. What is the further tactics of labor management? I believe we have talked about what primary inertia is all about. But again, what is primary inertia? Primary inertia is a prolonged latent phase. That is what is termed as what? Primary inertia. Prolonged latent phase. Prolonged latent phase. So usually in prolonged latent phase, we're having pregnancy is having what? Regular uterine contraction, but the cervix is not what? Dilating. Cervix is not dilating. It's not dilating. That's why it took like 18 hours for us now to have what? Full dilatation. Full dilatation. And usually when somebody is suffering from primary inertia, what we normally do is we give sedative to make the person what? Rest. We call it therapeutic what? Rest. Then we now give oxytocin for the person so it can help in the contraction. Oxytocin. Then we give to the person. That's the normal treatment management for primary inertia. Primary inertia. Now for second stage arrest, we give oxytocin, then forceps will be used when the fetal head is engaged. When the fetal head is engaged. So now over here, we have actually, yes, the person was diagnosed with primary uterine inertia. But for our management, whereby now the fetus is now engaged, it means that it has now moved from the primary inertia, isn't it, to the, what we call the second stage of arrest, which means that now the cervix is open, but the baby is engaged. Baby is engaged. Cervix is open and baby is what? Engaged. So now you use what? Forceps to extract the baby or to pull the baby what? Out. Now, if the fetal head is not engaged, you do cesarean section. If the fetal head is not engaged, you do what? Cesarean section. Now, in this situation, we are having what? The fetal head being engaged. That's what over here, you are going to use what? Forceps. Of course, the outlet forceps. The outlet forceps. So here, your answer should be E. Outlet forceps. All right. A woman is 40 weeks pregnant. The fetus is in a longitudinal lie and cephalic presentation. The pelvic size is blah. Expected weight is 4,800 grams. This is a big baby, isn't it? This is a big baby. Good. Now, the labor contraction have been lasting for 12 hours. Within the last 2 hours, they were extremely painful. Parturient woman is anxious. Water broke 4 hours ago. External examination. There's a contracting ring, which is what located. Contracting ring is located 2-finger width above the navel. Vasting sign is positive. Now, when we say vasting sign is positive, it means that there's a disproportion between the fetal head and the symphysis pubis. Disproportion between the fetal head and the symphysis pubis. Okay. Now, fetal heart rate is 160. It is muffled. Internal examination of the uterine surface is fully opened. The head is engaged and pressed to the entrance into the lesser pelvis. What is the most likely diagnosis? Now, due to the large size of the baby and, of course, the disproportion between the fetal head and the pubis symphysis, we can have a uterine rupture. What we're trying to talk about is that there is a threatened uterine rupture. Threatened uterine rupture. Because one, the baby cannot be able to pass through the cervix, even though it is fully dilated. Even though it is fully dilated. But we're having a point because the head is quite big and it's not able to fit through the lesser pelvis. It's not able to fit through the lesser pelvis to come out. So that is our problem. So if care is not taken, the uterine can rupture. But over here, rupture has not yet set in. So you can't say there's a uterine rupture, but there's a threatened uterine rupture. Threatened uterine rupture. That's over here. Your answer should be what? Should be E. Should be E. A 23-year-old woman came to the gynecological clinic, complaints of pain, itching, and burning in her vulva. General weakness, indisposition, elevated body temperature, and headache. On examination, the vulva has multiple vesicles, up to 2 to 3 millimeters in diameter, with clear content against the background of hyperemia and mucosal edema. Make your provisional diagnosis. Guys, this is definitely having what? Or this person is having what? Herpes infection. Herpes infection, of course. Genital herpes infection. Genital herpes infection. And again, we have type 1, we have type 2. Type 1 can cause the genital herpes, but most cases of the genital herpes are caused by type 2. Most cases of genital herpes are caused by type 2. And why are we saying that it is herpes? Because of the presence of multiple vesicles. Multiple vesicles. These are kind of what? Eruptions, which can usually appear and even disappear. They are what? Eruptions. Or what we normally know is that they are like sores. They are like sores. So over here, we're looking at what? Herpes. So the answer is A. Herpes. A woman with a pregnancy term of 8 weeks, complaint of elevated temperature, skin rash that can be characterized as a macular exanthema, enlargement of the posterior cervical and occipital lymph nodes, small amount of bloody discharge from the genital tract. She was examined by infectious disease specialist and was diagnosed of rubella. Guys, we've done this before. Now, if you are pregnant and you are diagnosed of rubella, please, the safest thing for us to do is to terminate the pregnancy. Because if you go ahead and give birth, this person will have a lot of genetic disorders or chromosomal abnormalities. And you don't want that. So this one, medically, we have to what? Abort the baby. We have to abort the baby. So over here, your answer should be what? Abortion. That should be your tactics. Abortion. 16-year-old girl. I repeat, 16-year-old girl has primary amenorrhea. No pubic hair growth. Normally developed mammary glands. That means she has mammary glands, but there's no pubic hair. Her genotype is 46XY. Look at the genotype. XY is for male. True or false? But this is a female. Female must have what? XX. But here we have what? 46XY. The uterus and the vagina are absent. Imagine a girl without uterus and vagina. What diagnosis is it? Definitely. From what we are having, we're having what? A testicular feminization syndrome. Feminization syndrome. So here, your answer should definitely be what? Be E. Be E. Don't get confused with it. So a girl with male features, or a girl with male features. Basically, that's what it means. 46-year-old woman came to the maternity clinic with complaints of moderate blood discharge from the vagina, which developed after menstruation delay of 1.5 months. On vaginal examination, the cervix is clean. The uterus is not enlarged, mobile, painless, appendages without changes. Make your diagnosis. Of course, there's not really much of a problem. Other than that, we're having what? A dysfunctional uterine bleeding. That's all. Because don't forget, the person was having what? Irregular menstruation. Because menstruation was delayed. It was delayed. So over here we have what? An abnormal uterine bleeding. Which simply means that we're having an irregular uterine bleeding that occurs in the absence of any recognized pelvic pathology. Any recognized pelvic pathology or general medical disease or even pregnancy. There's nothing like that because everything over here is okay. So we're having what? Just a dysfunctional uterine bleeding. So your answer here should be what? Should be A. A 25-year-old woman was brought into the gynecological department with a profuse bloody discharge from her genital tract. Again, we're having what? Discharge from her genital tract. Okay. Now she's 12 weeks pregnant. You are pregnant and you're having discharge. That is something that we have to look into it. Because if you are 12 weeks, or let me say first trimester and even second trimester, and you are having vaginal bleeding or profuse bleeding, all that we know is that abortion is setting in, isn't it? Yes, abortion is, because you're not supposed to bleed when you are pregnant. Now, and of course, if it is in the third trimester, then that's why we now consider what? The antepartum hemorrhage, isn't it? But for early trimester, we're looking at what? Abortion. In late pregnancy, we're definitely looking at what? At the antepartum. Good. Now, the pregnancy is planned. Okay. So they plan to have the pregnancy, unlike some of our young ladies who don't. Sorry. Now, within the last 3 days, she was experiencing pains in her lower abdomen that eventually started resembling cramps. She developed bleeding. Her skin is pale, pulse 88, pressure 160, temperature 36, cervical examination, uterus size correspond with 11 weeks of pregnancy. The cervical canal allows, guys, look, inserting of one finger and contains fragment of the fertilized ovum. Ladies and gentlemen, in the noble profession, abortion is already taking place. Abortion is already what? Taking place. So over here we have what? 12 weeks of pregnancy with what? A spontaneous abortion in progress. In progress. So unfortunately, we have to help the person to complete the abortion. So your answer is what? Is A. Is A. Is A. So unfortunate. A 30 38-year-old woman came to the gynecological department. She complains of a sharp pain in her lower abdomen and temperature of 38.8. She has a history of extra sexual activity. Extramarital sexual activity. What it means is that the person is cheating, right? Did they come out right? I think so. All right. And has 2 artificial abortions. Now, on a gynecological examination, the uterus is unchanged. It is unchanged. Appendages are bilaterally enlarged and painful. Profuse purulent discharge is being produced. Examination needs to be conducted to clarify what examination needs to be conducted to clarify the diagnosis. Guys, we're having a case of what? PID. That's pelvic inflammatory disease. Pelvic inflammatory disease. And one of the causes of it is people who are not, are not staying to one partner. They just have sex, just like enjoying themselves. So you want to what? Do what? Bacteriological and bacterioscopic what? Analysis to know the kind of infection this person is having. So you do what? D. You choose D. You choose D. Because it's a PID, pelvic inflammatory disease. So you want to know the bacteria that is happening, that is causing it to be having all these kind of symptoms. All right. So please be married, be faithful. But usually ladies are generally faithful, unlike some people I know, like Nene. Now it is the 3rd day after the first normal term labor. The infant is roaming in with the mother and is on breastfeeding. Objectively, the mother's general condition is satisfactory. Temperature is 34.6. Why is Uche raising the hand? Heart rate is 80 per minute. BP is 120/80. Mammary glands are soft and painless. Lactation is moderate. Unrestricted milk flow. The uterus is dense. Uterine fundus is located 3-finger width below the navel. Lochia are sanguinoserous, moderate in volume. Assess the dynamic of uterine involution. Guys, what do you think is happening over here? This is a normal condition. This is a normal thing. So we call it a physiological involution. A physiological involution simply means, or it is the process by which the uterus is transformed from pregnant to non-pregnant state. And these things normally what go on when the woman finishes giving birth, because normally the stomach is big, so it has to now contract and start transforming again to the normal size that it was before pregnancy. So all of these things, they are normal. They are normal. So this we have a physiological. So the answer is what? C. Physiological involution. A 28-year-old woman complaining of irregular menstruations and infertility came to the gynecological clinic. Menstruation occurs since the age of 15. Irregular with delays up to 2 months. On examination, she presents with, guys, hirsutism and excessive body weight. This can only, and with the fact that she's a woman and having irregular menses and with hirsutism and excessive body weight, guys, you are thinking of what? PCOS or polycystic ovarian syndrome. We've done this before. But again, let's go in again and then we'll see why it is polycystic ovarian syndrome. Now look at the ovaries. Now on examination, the uterus is reduced in size and painless. The ovaries on both thighs are dense and enlarged. Look at the ultrasound investigation. The ovaries are 5 by 4 centimeters and 4 by 4 times 4 centimeters with a dense ovarian capsule. Look at the basal body temperature. Monophasic. Guys, Every woman must have a biphasic. We've talked about this before. Your temperature cannot be just normal, like just once, like if it is 36.6 all the time. No. Because of menstruation, sometimes it will change. So every woman have what? A biphasic. One time you are hot, one time you are cold, one time you are hot, one time you are... That's how a woman is. Do you understand? That's why they have the mood strings and those kind of things. So those of you who have women, Alphonse, the numerous girlfriend that you have, you can ask them. Sometimes they're in a good mood, sometimes they're not in a good mood. That's because their hormones, their temperature is playing with them. Their hormones is playing with them. So over here, we're having what? A polycystic ovarian syndrome. Polycystic ovarian syndrome. So the answer is what? Is D. Is D. Again, why? Hirsutism, excessive body weight with irregular menstruation, and even infertility. And sometimes too, they will tell you that they're having what? Cyst. They're having cyst in the what? In the ovaries. Cyst in the ovaries. So all of these things goes on to elaborate or to put emphasis on the fact that we're having what? A PCOS or polycystic ovarian syndrome. An 18-year-old girl was brought into a gynecology department with complaints of elevated body temperature up to 37.8. There was sharp pain in her lower abdomen, more intense on the right. Sharp pain in her lower abdomen, more intense on the right. Difficult defecation. Vaginal examination. Guys, look at the vaginal examination. Painful, dense, elastic formation, 5 by 6 centimeters in the area of her right ovary. Pregnancy is negative. So that means you can't be thinking of what? Ectopic pregnancy. No. You can't think of what? Ectopic pregnancy. But what we can think of is torsion. 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 So over here, we're looking at torsion of ovarian tumor, what? Pedicle. Torsion. Torsion. So you hear your answer is what? Is torsion. It's A. It's A. It's A. Now, one of the risk factors for torsion is ovarian cyst, ovarian enlargement, ovarian tumor. Even pregnancy can cause it, and fertility treatment. They can all cause torsion of the ovary. It can cause torsion. Torsion. But the person cannot even visit the private. That is serious. So the answer is A, torsion. A 26-year-old woman presents with amenorrhea, absence of menstruation. 10 months ago, she gave birth for a second time. In her early, guys, look at it. In her early postpartum period, she developed massive, please underline massive hypotonic hemorrhage. No breastfeeding. Lately, she has been presenting with loss of weight, loss of hair, indisposition. Examination revealed atrophy of the external genitals, uterus abnormally small. No uterine appendages can be detected. What are you looking at for? Guys, we've talked about one of the complications of post-hemorrhagic, postpartum hemorrhage. One of the complications of postpartum hemorrhage, that's PPH, is that it will lead to what? Decreased perfusion in the pituitary gland. And you and I know that pituitary gland is involved in a whole lot of function in the body. In a whole lot of function in the body. So when that place is underperfused or undergoing necrosis, it leads to all of these what? Symptoms. And the medical term for postpartum pituitary gland necrosis is called Sheehan syndrome. Sheehan syndrome. And that is exactly what this person is encountering. Sheehan syndrome. This is not a physiological amenorrhea. No. Sheehan syndrome. All right. 45-year-old woman came to the maternity clinic with complaints of periodical pains, in her mammary glands that start one day before menstruation and stop after menstruation begins. It stops after menstruation begins. Palpation of the mammary glands detect diffuse nodes predominantly in the upper outer quadrant. What are you looking at for? Guys, we're looking at what? Fibrocystic mastopathy. Fibrocystic mastopathy. Commonly known as fibrocystic breast. Fibrocystic breast. And this is simply a non-cancerous or benign condition in which the breast feels lumpy. The breast feels lumpy. Usually it is not harmful and it is not what? Dangerous. But sometimes it's uncomfortable. It's uncomfortable because it may cause pain, breasts, and even some masses inside what? The breast. And usually all of these ones are due to hormonal what? Changes during menstrual cycle. When you're menstruating, there's some sort of hormonal influence that comes to influence the breast and things like that. That's if you see a woman who has started menstruating, you see her breast. You and I know that. Okay, let me not go into this. So basically, that is it. So over here, looking at what? A fibrocystic mastopathy. So the answer is C. Is C. This is not mastitis. This is not breast cancer. No. All right. A 14-year-old girl came to the general practitioner with complaints of weakness, loss of appetite, headache, rapid fatigability. Her last menstruation was profuse and lasted for 14 good days. 14 days. After the previous delay of 2 months, skin is pale, heart rate is 90, BP is that, HB is 88, rectal examination, the uterus and its appendages are without changes. No discharge from the genital tract. What complication has occurred? Guys, having menstruation that is lasting for 14 good days. No. This is what? Post-hemorrhagic anemia. Post-hemorrhagic anemia. That's long overdue. Post-hemorrhagic anemia. So the answer should be what? Should be B. Post-hemorrhagic anemia. Why? Because the menstruation lasted too long. And she started developing what? Anemia as a result. HB 88 is not good. Supposed to be 120 and above. All right. A 22-year-old postpartum woman on the 12th day after normal childbirth informs of elevated body temperature. For the last 3 days and pain in her right mammary gland. The right mammary gland is enlarged, okay? Hot to touch, tense, hyperemic, pain. These are signs of what? Inflammation, isn't it? These are signs of what? Inflammation. But again, look, palpation reveals a dense infiltration. Dense infiltration. So infiltration is not there for being there sick. With fluctuation in its center. What are you looking at? Of course, this is what? Postpartum period occurring on day 12. Okay. Now, which side of the breast is this occurring? It's occurring on the what? The right side. So we have a right-sided infiltrative purulent mastitis. Right-sided infiltrative purulent mastitis. Why? It's already in the question. So please, don't get confused when it comes to this one. So your answer here should be what? Should be A. Should be A. All right. 35-year-old pregnant woman with first-degree essential hypertension developed edemas and headaches at the 33rd week of her pregnancy. Okay. So hypertension, edema, headache, guys, preeclampsia, isn't it? Objectively, her general condition is satisfactory. Blood pressure is 160. Oh, normal uterine tone, fetal heart rate, 140 per minute, rhythmic. She was diagnosed, guys, Lucy, Proteinuria is 4. Don't get more than 0.03. Daily diuresis is 1,100. Creatinine is 80. Urea is 7. Platelet is blah, blah, blah. What complication of pregnancy? So, guys, we're even having what? Preeclampsia. We're having what? Preeclampsia. And I think I remember giving you some things to classify the different types of what? The severity of a preeclampsia. The severity of a preeclampsia. But definitely, this is a preeclampsia because preeclampsia has a classic triad of what? Hypertension, proteinuria, and edema, which of course is present in this patient. So now let's write this again. I know I've said it a long time ago in one of our presentations, but for the benefit of those who just joined us, let's go over the different types or the severity of a preeclampsia. One, we have in mild preeclampsia. What do we have? The BP is greater or equal to what? 140/90, and proteinuria is greater or equal to 0.3. Mild again, BP greater or equal to 140/90, proteinuria is greater or equal to 0.3. In moderate, BP is greater or equal to what? 150, greater or equal to what? 150. Proteinuria is greater or equal to what? 3. Greater or equal to what? 3. That is for what? For moderate. Now, in severity, BP is greater than 160. Greater than 160, and even sometimes it can be 160 or more. 160 or more. Then we have proteinuria should be greater or equal to 5. Greater or equal to what? 5. Greater or equal to what? 5. And again, for severity too, it is accompanied with severe headache, epigastric pain, visual changes, thrombocytopenia, elevated liver enzyme, pulmonary edema, and oliguria. When we say oliguria, that means diuresis should be less than 750. Less than 750. Now let's come back to our question. Now we are having diuresis of 1,100. So again, this is not what? This might not be what? Severe. Proteinuria is 4. We said in severe must be what? 5 or more. Although the blood temperature, the blood pressure is 160, which technically classify it to be, severe. But looking at the other parameters, we can describe this as, as severe. Because even look, the general condition of the patient is satisfactory. So there's no HELP syndrome, which I mentioned, the HELP syndrome. Hemolysis, elevated liver enzymes, low platelets, and that kind of thing. This is not present in this patient, or they didn't mention it in this patient. Okay, so over here, this can also be mild, but rather we consider what? Moderate preeclampsia. So again, your answer is moderate, or D. Is D. Please, we've done this before. So if you have any question, please do watch the video. I elaborated it very well for us to understand. So please, don't get confused. A 24-year-old pregnant woman on her 37th week of pregnancy has been brought to the maternity obstetric service with complaints of weak fetal movement. 37 weeks, weak fetal movement. Guys, look at the fetal heart rate or heartbeat. 95. 95. So this person or this baby is in distress. So there's fetal what? Distress. Fetal distress. But look at it. On examination, the uterine cervix is tilted backwards. When we say that the cervix is tilted backwards, it means we have a retroverted uterus. Or we have what? A retroverted uterus. And your uterus is supposed to be what? Retroverted. It shouldn't be backwards. Now, the external orifice allows inserting a fingertip. That means it's open, isn't it? Biophysical profile of the uterus equals 4 points. What tactics of pregnancy management should be chosen? Guys, we are having a baby who is in distress, whose mother's womb, or whatever you want to put it, is retroverted. What will you do? Immediately do your cesarean section. You do it. So you do what? An urgent delivery via a cesarean section. Urgent delivery. Otherwise, baby could die. The baby could die. The baby could die. So please, answer is C. During regular preventive gynecological examination, a 30-year-old woman was detected to have dark blue punctulated perfusions on the vaginal portion of the uterine cervix. The doctor suspects endometriosis of the vaginal portion of the uterine cervix. What investigation method will be most informative for diagnosis? Of course, if you're talking of what endometriosis, whereby what it means that there's lesion that's occurring on the outside of the cervix, isn't it? Because we have what? Endometriosis of the cervix. Endometriosis of the cervix. So usually what do? You have to do what? A colposcopy to examine the cervix, the vagina, and even the vulva for any sign of what? Of the disease. So you do what? A colposcopy. So your answer here should be what? A colposcopy. And of course, you will take what? A biopsy to analyze the cells or to analyze the tissue over there. So the answer is what? Is A. Is A. A parturient woman is 30 years old. Stage 1 of the labor is ongoing. The fetus is in a cephalic presentation. Auscultation of the fetal heart sounds detects bradycardia. Guys, I've given you guys an assignment before, right? Am I right, guys?
Yes.
Okay, don't worry, we'll come to that. Auscultation of the fetal heart sounds detect. The reason why it came to my mind because I wanted to give you guys another task to tell me the different stages of labor and what it mean by stage 1 of labor is ongoing. So it's also added to your assignment. So after that, we'll talk about our assignment. Evaluation of cardiotocogram yielded the following data. There's a decrease of basal heart rate down to 90, variability, monotonous, to a late deceleration with amplitude of 50 per minute. Make the diagnosis of the tactics necessary in this case. So again, what do we have? We're having what? Fetus is they're telling us that labor is ongoing, but the fetal heart sounds is having what? Bradycardia. And we've already established that if you're having a bradycardia or when the baby is having a bradycardia, definitely the person is in distress or the baby is in distress. So if the baby is in distress and labor is already ongoing, what are you going to do for this woman in order to save the baby? That's what this question is all about. What are you going to do to save this baby? Now, if you allow this labor to continue by vaginal delivery, I can bet you it can lead to a stillbirth. So what we want to do is to do what? A cesarean section. We've discussed it in our previous two questions, if I'm correct. Fetal distress, please consider cesarean section, especially if the baby is not engaged. All right. So your answer here is what? Is E. Is A. All right. A 27-year-old woman complains of foul-smelling discharge from her genital tract, pain in her lower abdomen, and elevated temperature. The complaints arose 2 days ago. History of, guys, look at the history. Surgical abortion at the time of 8 weeks, 1 week ago. On examination, the uterine cervix is clear, external orifice produces foul-smelling discharge. The uterus lies in anteflexion, mobile, painful, and slightly enlarged. Appendages are without changes. What is your provisional diagnosis? Guys, we can be looking at what? Endometritis, because it's a little bit what? The uterus a little bit what? Enlarged. That means could be what? Inflamed. For that reason, we're having what? A foul smell what? Discharge. But this endometriosis is as a result of what? Of the abortion that was done. Or the surgical what? Abortion. Even though it was surgically done, maybe prophylaxis were not given. Prophylaxis were not given. Because if prophylaxis is not given, you can develop what? Infection in the womb. So over here, we're having what? A post-abortion or post-abortal endometritis. Endometritis. So the answer is B. All right. A 17-year-old girl has made an appointment with the doctor. She complains, she plans to begin her sex life. Oh, that was wonderful. But 17-year-old girl, if you go and tell this to your mother, then you want to start having a sex life, maybe they will slap you. Meanwhile, 15-year-old girl or 10-year-old girl is having sex because they are afraid to tell their parents. So they'll not go for an appointment like this to check if they can have it or not. You can ask Alphonse. Alphonse can tell you that. I know. Alphonse can tell you. Now, no signs of gynecological pathology were detected. In the family history, the patient's grandmother had cervical cancer. Cervical cancer. The patient was consulted about the maintenance of her reproductive health. What recommendation would be the most helpful for prevention of invasive cervical cancer? Now, you know that cervical cancer is caused by what? The human papilloma what? Virus. Isn't it? Yes, it's majority of it is caused by what? About 90% of the cases is caused by the human papilloma what? Virus. And you know that the HPT also has what? Vaccines against it. Or we can have vaccines against it. So to prevent it, you do what? A vaccination against the HPV virus or the human papilloma virus. And that's over here. Your answer should be what? Should be A. Should be A. All right.